Hi, good afternoon, good lunchtime. Welcome everybody. So this is Dr. Javanji's organises this meeting, Congenital Heart Hour, and he's been running it successfully for over a year now. Unfortunately, he's not here today, so he's asked me to introduce Dr. Jones, who is our clinical lead. She is paediatric and fetal cardiologist here at Liverpool, at Alderhay and in the Northwest. The meeting is sponsored by Medtronic, so thank you to Medtronic for that. And hopefully we have listeners online as well, but if you just put any questions in the chat and then we'll get to them at the end of the meeting. So I'll just let Dr. Jones present today. She's presenting on neurodevelopmental outcomes in transpositions of great arteries.
Thanks, Soph. Okay, so this is a little bit of a whistle-stop tour, and I guess it speaks more widely to neurodevelopmental issues in critical congenital heart disease as a whole, but I have focused on the transposition group in this presentation. I'm going to run through a little bit about the fetal circulation and how that might affect the development of the brain in prenatal life. We're going to have a little look at neonatal imaging and brain injury that we can see in this group of patients. We're going to have a think about what the timeline of treatment is for infants with transposition of the great arteries and how that might impact on brain development. And then we're going to have a look at some of the outcomes in this specific group of children, both early school age and into young adulthood. And then we'll just have a think about how we might perhaps make some impacts on this area and hopefully improve outcomes for some of our young people going forwards. So I think we all know this. It's safe to say that congenital heart disease over the last 20 to 30 years has been obviously a huge success story, particularly in our children who undergo high-risk biventricular neonatal repair. Results coming out from the UK nationally and NICOR show that mortality is really at an all-time low. So 1.6% for all comers at 30-day mortality, which is really plateauing now and probably where we're going to stick for a while. We know that we're seeing increasing antenatal diagnosis. So around 54% of children undergoing intervention in the first year of life will have an antenatal diagnosis. That will be higher in infants with transposition of the great arteries, and that might give us some way of having a look at these children a little bit earlier and thinking about their brain development and how we might make some interventions there. And we know complications are remaining fairly low. So that's led us in the last 10, 20 years really to more nuanced, subtle focus in terms of impacting on longer term outcomes. So in terms of being a fetal cardiologist, actually, most of the time, families, they obviously want to know the chance of survival, but that's less of the focus in terms of 20-week diagnosis counselling. People are obviously more concerned about if their child comes through the operation, what their quality of life is going to be like, what are going to be their impacts on going to school, having a job, having a family of their own. And how that sort of ongoing need is going to affect perhaps siblings, the wider family. We certainly know there's huge effects on the family as a whole in terms of financial burden, impacts on families and siblings, potentially relationship breakdowns, change in lifestyle, ability to work. A neurodevelopmental outcome is a big impact on those subsequent things. So it's becoming increasingly important that we're talking about neurodevelopmental outcome, even from early diagnosis. So we've obviously been looking at this for a while and it's immensely complicated. So if we look at the circular diagram on the left-hand side, we can see the determinants of neurodevelopmental outcome in congenital heart disease are hugely wide-ranging. Some of it might be intrinsic, so genetic or syndromic children we know have a much higher rate, obviously, of either learning disabilities or other challenges going forward. We can see there's preoperative factors, be that cerebral blood flow in utero or in the preoperative period, environmental exposures, clearly the perioperative period, particularly around the arterial switch and balloon atrial septostomy in infants with TGA, is massive, where we can see hypertension, hypoxemia, reperfusion problems, inflammation, hypothermia, and then obviously in the recovery following the arterial switch, many other things in there. They're interesting. I see in the post-operative, it's interesting they've put socioeconomic status. You could, some of these things play out throughout the whole patient journey, parental stress and other things like that. So there's really determinants of neurodevelopment going on for a long period from the prenatal period right through to childhood. So the graph on the right is from Gil Vinosky, and unsurprisingly, this is just looking at the severity of the congenital cardiac defect on the x-axis against what degree of impairment, be it mild or combined disabilities to severe impairment. And as we can see on the right, we know our children with genetic or syndromic diagnoses can have obviously very high rates of difficulties and disabilities, and then our complex palliated children. And then in the severe group, we can see probably 2/3 still of our patients may have anywhere ranging from a mild or combined disability to a severe impairment. And I think it's important to recognise, even in some of our patients with mild congenital heart disease, there's a small but significant proportion who may have mild or combined disabilities that affect them throughout childhood. So I'm just going to go back to the fetal circulation just to think about how that might affect brain development, particularly in the context of transposition. So people have been studying fetal circulation from the 30s, and then much of the major work was done by Rudolph and team, published in the 60s on the fetal lamb, where they'd actually externalize the fetal lamb in utero and measure the oxygenation of the blood to different organs, the pressures and various other things. So we know that the oxygenated blood is coming from the umbilical vein through the ductus venosus, across the IVC, and I'll show you the diagram in a minute. There's some complex streaming that goes on with the eustachian valve and the foramen, which means that oxygenated blood in the normal fetal heart is preferentially directed up through the left heart to supply the fetal brain. That's obviously very different when we've got transposition. So 1/3 of the oxygenated blood from the placenta crosses through the foramen and perfuses the head, neck, and upper trunk. And you can see on the diagram on the right how that works in terms of the foramen flap valve channeling that oxygenated blood. So we've began to get new insights into some of the fetal circulation using prenatal fetal brain MRI, which I think probably 60 to 80% of the papers we're going to look at today are from Mike Seed and the group at Sick Kids in Toronto, who've studied this extensively. And it's fascinating now that they can sort of reproduce the fetal hemodynamics using MR, basically, to have a look at oxygenation delivery to various organs in utero. So on the left-hand side, we can see the normal heart. And again, we can see that oxygenated blood coming back via the umbilical vein through into the left heart and perfusing the brain. This gives us a saturation here. And obviously, when we've got that parallel circulation, that oxygenated blood coming back to the left ventricle is then being preferentially streamed to the fetal lungs. So you can see the oxygenation of the fetal brain in transposition is not normal. Though it's receiving good blood flow, the saturations in the brain prenatally do affect how the brain is developing from very early on. So this is one of their studies looking actually at all comers with congenital heart disease against normal subjects, looking at brain volumes prenatally. So we can see significant differences. We've got 30 fetuses in each group, significant differences in mean fetal brain volumes, which correlates with differences in the ascending aorta saturations. And we can see some changes in mean cerebral oxygen consumption. So again, we've got cerebral oxygen consumption here on the right-hand side and brain volume. So these babies have abnormal brains even before they're born and exposed to the other things which we know impact them significantly. Or if I skip the slide. So if we look at brain development, we know it starts from the 3rd week of gestation, but actually continues into early adulthood. The brain is initially very smooth, and later on you see that gyration. It's not I feel like it's a longer word than that. That's not gyration. We can see that is a much later thing. There's a hierarchy of connections that develop, and we can see differences between. So at the bottom here, again, this is another study from Gilvanovsky. This is looking actually at hypoplastic left heart syndrome, but we can see the indices of gyration. Someone shout out the word if they know what it is. We can see the infants with hypoplastic left heart syndrome have a much smoother brain that's more immature compared with normal controls. And we can also see differences because of that in the surface area of the brain. So this is, again, happening very early on. And just thinking how this sort of relates, we'll come to sort of the timeline, but we can obviously see at the bottom here diagram what's going on in terms of brain development before birth, but it's important to realise how much brain development is going on in the first, particularly 2 years after birth. So we can see an increase of 100% in brain volume in the first year of life, and then there's another 15% by the 2nd year of life. And it's interesting that there's a lot of analogies to the preterm brain, so that a lot of infants with significant critical congenital heart disease, and again, we're particularly looking at transposition and hypoplastic left heart syndrome where the perfusion isn't normal. We can see the brain is very similar to the preterm brain, and it's in that it's more immature and smoother, and it's much more vulnerable to insult. And within that brain development, we know that there's regions of the brain that are much more vulnerable, particularly the frontotemporal lobes and hippocampus. So it's just thinking in terms of transposition, the whole timeline of our treatment throughout this period, the brain's in a really critical phase of development. So during the development, we can obviously see hypoxia, altered cerebral perfusion. We know that these infants are much more likely to be born preterm. We can see from many other fetal studies there's an impaired fetal environment anyway. There might be placental function problems going on, and additionally genetic or syndromic diagnosis. We've obviously then got the transitional circulation. So as the circulation transitions over, it's a particularly vulnerable period. We then go on to do a blue natral septostomy, which is well documented to have a risk to the brain. So we know that we can see small strokes when we study these group of infants, and we'll have a little bit of a look at that later on. And we know there's a lot of hemodynamic instability, so potentially hypotension, high doses of prostin, depending again whether we've made an antenatal or it's a postnatal collapse diagnosis. And then clearly surgery is a huge test on a brain that is already immature and vulnerable. So cooling, deep hypothermic circulatory arrest, obviously bypass time, big inflammatory response. And then again, post-operatively, we know that prolonged ventilation has an impact on brain volumes and development. And we may be needing to do repeat interventions in some of these babies. So if we look at fetal brain imaging, this is a cohort study across three sites. And what it was actually looking at is brain volume. So initial brain volume and how that related to acquired clinically significant white matter injury in infants with transposition. So the graph on the left-hand side is, get my pointer, infants with transposition. This is infants with hypoplastic left heart syndrome. So on this graph here, we can see gestational age at the bottom and the brain volume. And the ones in red had no or a mild white matter brain injury, and the infants in orange had a moderate or severe white matter brain injury. So we know that smaller brains are more vulnerable to having a white matter injury in the either pre or perioperative period. And it's fairly significant, I think, to us as a unit who don't do a lot of brain MRI in our TGA infants. This in some ways is slightly invisible to us in terms of what might be going on. But if we look at the 37 infants with transposition, 19% of them had a mild white matter injury and 10% actually had a moderate or severe white matter injury during this period. 8% were seen to have a small stroke. Many of these sort of injuries may not be clinically apparent at this stage, I think it's safe to say, but there's clearly good evidence that it might show signs later on in terms of how a child develops. So if we look at the effect of antenatal diagnosis, I think this is the difficulty of pulling out some of the patterns in terms of neurodevelopment. There's obviously a huge amount of determinants and some things which may protect some of our infants. So this was a cohort of 139 babies with transposition of the great arteries, of which around half of them were prenatally diagnosed. And they looked at the total brain volumes before the switch and after the switch using MRI, and then they looked at 18-month cognitive outcomes. So interestingly, the interaction between antenatal diagnosis and total brain volumes were significantly related to cognitive outcomes. Smaller total brain volumes were associated with lower scores, as you'd expect in the postnatal group, but there was less effect seen in the antenatal group. So again, with the postnatal group, you could maybe postulate that there's other determinants going on in terms of their preoperative state, hypotension, and other things that meant that was more observed. That relationship between brain volume and scores was seen more in the postnatal group than the antenatal group. This is another study from Toronto Sick Kids looking at the timing of the arterial switch procedure and and the effect that has on brain volumes. So they looked at, I think over the period, they had 90 infants undergoing an arterial switch for transposition, of which 45 were eligible or recruited to this study. They looked at brain weight Z scores calculated on brain volumes and reference data, and then they looked at neurodevelopment only at 18 months using the Bayley-3 scores. Again, surprisingly, fairly high noted radiographic evidence of white matter injury. So moderate or severe white matter injury was observed in 10 of the 45 infants with TGA, and 4 of them were noted to have small strokes on their brain MR. So we can look at these box plots here. So brain weight Z scores, we can see early repair versus late repair. So they looked at late repair even 2 weeks post, can't remember the dates now as to how they classified the late repair, but we could see already that even leaving the switch 2 weeks later, you can see the difference in the brain volume. So it's quite pronounced. And interestingly, we've seen other data on meetings before about outcomes following switch and leaving it later, perhaps whether that's related to, again, transitional circulation and pulmonary vascular resistance. But you can see the difference in brain size if you leave the switch even a couple of weeks later. Interestingly, they did see a difference between the TGA group that had an intact ventricular septum and those who had a VSD. And again, when they looked at the pre-op MR and the post-op MR, there was also changes in brain volume, which was more significant in those who had a late repair. So the brains changed in those they repaired later compared with the early repair group here. So again, when they looked at post-operative brain volume Z score and plotted it against the age of repair, there was a significant correlation there. So risk factors for impaired perioperative brain growth in infants with TGA were VSD and older age at surgery. And some of that was borne out in their developmental sort of cognitive scores at 18 months. So they saw that older age of surgery was associated with slower language development measured at 18 months.
Sorry, so
it's okay.
Those with the BSD tend to do bad.
It seems to be, yeah. It's interesting, isn't it?
Is it because of the delayed surgery done or?
That may be a reason, yeah. Okay.
I would have thought they would have adjusted because they've looked separately at late repair. So, yeah, it's I can't quite.
Yeah.
So this is now sort of looking at more effects long term. So this is 165 neonates. Again, there's many studies on transposition, and then probably the commonest overlap is this is transposition and infants with single ventricle physiology. Again, these infants had preoperative and postoperative brain imaging, and then neurodevelopmental outcomes were measured at 12 months and 30 months. Small strokes and the use of balloon atrial septostomy was not associated with significant impairment. Good news for the interventionalists in the room. However, that group that we saw with moderate to severe white matter injury were on average 1 standard deviation below the normative mean for their motor development at 30 months. Again, so there's quite a few markers that we can see when we look at things where you can sort of describe, should we say, a phenotype of infants with congenital heart disease who might be more vulnerable to acquired brain injury and are going to be in this group in terms of being more significantly affected later on. So we can do prenatal imaging to actually look at the total brain volume, which is going to show us those infants who are probably more vulnerable. And then both pre and post-operative brain MRI does correlate with outcomes. I think.
Okay, sorry.
Mm-hmm.
The hypoxia, which is what causing all this brain problems.
I think it's probably predominantly it is the low, in terms of prenatally, it's the brain being delivered low oxygen. I mean, it's a postulation, but it's low oxygen being delivered to the brain because the actual obviously blood delivery, particularly for transposition, there isn't a problem with the blood being delivered to the brain. It's just being given desaturated blood.
Postnatal hypoxia causing because tetrahydrogen fellow the saturation will be 70s. Have they compared all these things?
I think tetralogy is probably less studied. I guess it's kind of slightly different in terms of transposition. You've got a number of really acute neonatal. So in tetralogy, you're not going to be doing any. Not having. Most of them aren't having neonatal bypass surgery. Most of them will not be hypotensive. So I think the transposition group are a bit more complicated because there is literally multiple insults in terms of the brain development in the first month, which is why they're so well studied. Whereas we know that there's another group of infants who have chronically low saturations, but good perfusion, no hypotension, no neonatal brain surgery, who seem to do better, yet they still might be blue or have saturations of 70 at 2 and 3, but there's less. Again, I think there's certainly obviously much more inherent variability and vulnerability in the neonatal period of doing anything. And I think some of it is so acutely studied because it is the timing of neonatal surgery. It's that kind of they're born preterm, leave the brain for 4 weeks, and I think it's constantly shifting in terms of pros and cons of when to operate.
It's usually the only one where if you've got low sats, your lowest sats are to the brain. I normally you are preferentially doing the better blood to the brain. But in TGA, it's the worst blood. It's low glucose as well.
Yeah, I mean, in the infant, so in fetal life, in the infant with tetralogy, they'll have normal. So it's And I think that's what's interesting about some of these studies is it's the fact also because it's not been normal, it seems the brain's more vulnerable because it's not developed normally. So, if you didn't do anything, but none of these conditions, you can do nothing, you may then come out of that vulnerable period, but obviously you're forced into to do things. But I think it's the prenatal sort of priming, shall we say, of how the brain develops, which then makes it much more vulnerable in terms of having to undergo all these other interventions that are a problem. But
would you also be getting all the nutritionally poor blood as well, though, because that's all going straight to the lungs as well, isn't it, in TGA? Like the sensible blood flow is not coming through the brain first, is it? So you get the dregs.
The brain gets the dregs. Yeah. It's a better word. So if we look at outcomes in transposition specifically at school age, we know that IQ scores are generally within the normal range, but are lower than expected or lower than average when compared to peers. I think the big things that seem to be coming out are that attention and executive function difficulties are extremely common and seem to be quite specific in this group of patients. We can see some delays in fine and gross motor skills, and there seems to be poorer coordination that may be noted compared to peers. Expressive and receptive language delays may occur. Again, I think that's evidenced in the infants with the more moderate and severe white matter injuries. And we know, particularly in older age school children, there are higher rates of anxiety, depression, and social difficulties. So this is a Boston cohort of young people with transposition of the great arteries who were studied at 8 years and 16 years. Interestingly, so there's two sort of the reference sample here are, I presume the reference sample live in Boston. You're obviously happier and more intelligent if you live in Boston than if you're a published data set on, because there's some difference here when they compared, they did statistics against their own reference sample compared to normative data that's published for 16-year-olds. But you can see there's significant differences if we look to the reference sample at 16 years across psychosocial functioning, emotional, behavioural functioning, mental health, and again, quite specific things around attention and executive function were brought out in this study. So in terms of adolescents and young people, again, IQ scores generally within the normal range, greater risk of attention deficit hyperactivity disorder, executive function, deficit in overall memory abilities. Again, academically, usually that's not borne out in terms of, should we say, IQ or academic achievement, but we can see evidence again of depressive anxiety, post-traumatic stress symptoms, which are elevated in some studies, and similar problems seen in the adult population with transposition of the great arteries. So I guess for me, in terms of the role of a paediatric cardiologist in this, I think really it's important as fetal cardiologists, we're actually talking about some of this at 20 weeks. I think we've all seen as paediatric cardiologists some young people who've had an excellent repair of their biventricular congenital heart disease, but have absolutely huge difficulties either at school or with behavioural difficulties, be it autistic tendencies, ADHD, behavioural difficulties that are actually then become the biggest determinant of their outcome rather than their congenital heart disease, which has been really effectively treated. I do think it's a very challenging time, obviously, in terms of access to child and adolescent mental health services. I certainly find it very difficult to get many of the patients that I see in clinic reviewed. I'm not sure how we combat that. There's huge waiting lists in terms of access to services generally. I think we do need to have a proactive approach. So particularly the team in Ireland, in Belfast, have got a really interesting sort of entry to school programme for their congenital heart disease children. I think we're really focused on talking to school about exercise, what they can do in PE, what they can't do in PE, which actually for most of our children with transposition isn't a big issue. What we should be talking about is, can they learn in lesson? Can they sit still? Can they focus? How do they behave with other children? What difficulties are they facing? And I think we probably just don't really talk about that as much as we should do. So we need to be educating and empowering the families to look out for that, I think, particularly as children are going into school. And again, I think the research agenda is focusing more on looking at these things and how we mediate against them. So in terms of what's going on at the moment, there's obviously a lot of research focusing on specifically improving neurodevelopmental outcomes in this group of patients. I think certainly as a fetal cardiologist, there's obviously huge focus on the fetal maternal environment and how we might improve it, how we might be able to improve placental function. People are doing studies into hyperoxygenation. Is there any way we can improve the blood flow to the brain? Things we've been doing for years, I guess, in terms of neuroprotective strategies around surgery to minimise brain injury, particularly during vulnerable periods. I do think there's lots of innovation going on around imaging, obviously, to try and pull out the markers of infants who are particularly vulnerable. Do we need to be treating these babies with small, immature brains differently? And then, as I say, we need longer outcome studies, particularly when I'm speaking to someone at 20 weeks. It's really useful to have that longitudinal cohort data to say what are most children like when they're 18, when they're 20, what are they able to do, what difficulties do they have? So I think in summary, fetal brain imaging may identify some of these babies who are at higher risk of a later or acquired brain injury in the peri-operative period. I think there's evidence that neurodevelopmental issues can affect around half of the children in this group, and they do correlate with that early imaging. It's important that we incorporate this information into our counselling, as I say, at fetal diagnosis, but also peri-operatively. And then again, when we're seeing children, particularly young children, nursery age children in our clinics, it's important that we speak to families about this, to keep an eye out and engage with schools really to try and identify these children so we can give them the right support. We hope, obviously, identifying them may mitigate against some of the longer term problems we're seeing with anxiety, depression, and social difficulties. If anyone in the room has any questions.
Thank you.
Arvind.
There was extensive evidence of neurodevelopment coming from US and Canada. So is there any from a neurodevelopment point of view, is there a suggestion of what would be the ideal age for doing a switch in intact septum population, like which gives the optimal, because even early switches are known to cause neurodevelopmental neurology?
Yeah, I think what it doesn't speak too much on here is the preterm population or low birth weight, which I think is where the real challenge comes in. I think most of the evidence in 2.5 kilos and above term baby with switch suggests probably the earlier the better. But like you say, probably not 40, it doesn't give us a day. We used to have a surgeon who was always like, Norwood would be day 5, has to be day 5. But I think all the brain evidence and the other evidence suggests that leaving it probably is associated with worse outcomes. I think it's even more complex though if you've got a baby who's 2 kilos or 34 weeks gestation.
Agreed for 1 week to 3 weeks. Second week. That's what we discussed last couple of months ago.
I'm not sure there's a magic answer. As I say, I think as long, for me, it's interesting. They just did 2 weeks, but I haven't seen we've got that granularity of detail on, like, you know, plotting the day against the, you know, have to do an absolutely huge study, but I think there's evidence that you shouldn't leave it. It's really, yeah.
Do you think is surprising?
What's
Yeah.
Your surgery going more bypass time, those kind of things, isn't it, combined? Essentially, it's just related to the.
Potentially, it's difficult to tease out, I think, really, because it's interesting, as you say, it's quite interesting, because usually in terms of counselling, we consider a VSD in TGA fairly benign. It's just like, well, it's like, it was almost like, you know, a buy one get one free. You'll have the VSD closed. In fact, you might mix a bit better. You might not need a septostomy, but maybe there's other complexities in there that we haven't quite thought about. Yeah.
I think that's a good approach, and being a bit more proactive, because a lot of, so you said there's quite high mental health, you know, as opposed to neuro disability, there's also mental health issues, which maybe if you're on the ball with earlier in the life, you might offset some of it, like anxiety, depression. We've not thought about that, because we're all so happy about this switch coming into zone and that being great. The longer term stuff was, so do they survive? Are they okay? Can they exercise? But we think that thought process.
Well, I think we just haven't really got very good programs, have we, compared with, if you look like it. So I think, again, if you analogize it to like preterm delivery and the neurodevelopmental follow-up that ex-preterms get, and neonatal input, and everyone's focused on that side of things, it's actually, this group of patients are very, very similar. But we really don't have any formal program for sort of assessing them or intervening. Even our patients who have, so we had a bit of a chat with Adil and Marie, you know, even our ECMO program patients don't have a robust neurodevelopmental follow-up, but these are huge, you know, they're just such a high risk group. And I think we know where the high risk groups are, be it ECMO at the top, hyperplast, TGA.
So I guess we don't have resources, but they are
Which, yeah,
almost easier things to make longer term outcomes better. Like, if we're not focused on that at the moment.
I think that's why it's like you say, it feels more acute in TGA, because we know we've fixed the problem, and actually they should have a normal. We want them to have a normal quality of life, but if we're not recognizing the problem and addressing it, and then, as you say, the adult effects of anxiety, depression, and all the rest of it, it's we're missing a key bit of the outcomes, I guess. Yeah.
Is it fair to say the majority of the hit is postnatally then, based on what data?
I think I guess it's a bit chicken and egg, really, because it does seem to correlate that the prenatal brain volume is strongly determinant of whether you get a peri-operative hit. So it's kind of a bit of a I mean, the difficulty is we're obviously trying to minimize peri-operative brain injury for everybody. So it's, you know, in some ways, I guess if we knew about it, I guess all it would probably do at the moment is, if you knew about it, you'd target those patients for neurodevelopmental follow-up at 3 years and 5 years and try and be. So it seems like your prenatal brain development may dictate whether your vulnerability to brain injuries, which again, I guess is similar to doing the switch in a 34-weeker. It's just like there's that immature brain that's more vulnerable to the surgery than a term brain is. So I think it's a little bit chicken and egg. Yeah. Okay, thanks everybody. Thanks everyone. Bye.